Hello, and welcome to this Advocate Chat as part of the Alamo Breast Cancer Foundation's Advocate Program, held in conjunction with the San Antonio Breast Cancer Symposium. My name is Michelle Tregear, and I am the Chief Programs Officer for the National Breast Cancer Coalition. I also have the privilege of serving as an advocate on the Translational Research in Oncology, or TRIO, Breast Cancer Scientific Advisory Committee, and I'm a founding member and part of the leadership team of the Common Sense Oncology Initiative. Today, I am honored to be joined by Dr. Sara Hurvitz, a distinguished medical oncologist and clinical research leader who has dedicated her career to advancing breast cancer treatment and research. Dr. Hurvitz is currently a professor of medicine at the University of Washington School of Medicine, where she serves as the division head of hematology oncology. She is also the senior vice president of the clinical research division at the Fred Hutchinson Cancer Center. With a medical degree from the University of Southern California and extensive training and experience from her time at UCLA, where she served as a chief resident and completed her hematology oncology fellowship, Dr. Hurvitz has established herself as an international expert in breast oncology. Prior to accepting her leadership role at the University of Washington and the Fred Hutch, she led the breast cancer clinical trials program at UCLA for 17 years and served as the medical director of the Johnson Comprehensive Cancer Center. Over her remarkable career, Dr. Hurvitz has led numerous clinical trials, including many groundbreaking studies on CDK4/6 inhibitors, a class of drug that has really revolutionized the treatment of breast cancer. Her contributions to the field have been recognized with numerous awards, including the prestigious European Society of Medical Oncology Breast Cancer Award in 2023. Today, we'll be discussing the current landscape of CDK4/6 inhibitors in breast cancer treatment and the evolution of this therapy and what the future holds for patients. So Dr. Hurvitz, thank you so much for joining us today.
Thank you so much for having me, Michelle. I'm really happy to be here.
Great. Well, so to get started, let's dive into a little bit of background on the history of CDK4/6 inhibitors, which have really become such a pivotal part of breast cancer treatment. So Dr. Hurvitz, to set the stage for our discussion, could you explain first off what CDK or cyclin-dependent kinases are, their role in cell function, and really why they are important in the context of cancer?
Absolutely. Every cell in our body is highly regulated in terms of when it's allowed to divide. That cell division process is so controlled because, as you can imagine, if you have uncontrolled cellular division, you'll have cells grow and grow and grow, and that will form a tumor. And indeed, one of the hallmark features of cancer is unregulated cell division. So what the cell has in order to control that cell division process is a cell cycle checkpoint. And that checkpoint is controlled by a tumor suppressor protein known as retinoblastoma. Retinoblastoma is sort of like holding up the stop sign on the cell saying you cannot undergo cell division. In order to allow the cell to go through cell division, which does happen normally in normal cells of our body, there are a number of enzymes or kinases, which are proteins, that tell that stop sign to go from red to green, to turn on. And kinases, like cyclin-dependent kinases, control that checkpoint, that cell cycle checkpoint. Cyclin-dependent kinase 4 and cyclin-dependent kinase 6 are really important regulators of this in terms of allowing the cell to undergo cell division. Scientists have figured out over the course of several decades that dysregulation of this cyclin pathway, the cyclin-dependent kinase pathway, is implicated in the development of cancer. And that led scientists to look at whether you could inhibit aspects of cyclin-dependent kinases in order to stop tumor cells from dividing.
Okay, well, so following that, then, can you elaborate on what CDK4/6 inhibitors are and how they actually work in treating breast cancer?
Absolutely. So cyclin-dependent kinase 4 and 6 are really important in turning off that retinoblastoma signal. And so scientists developed inhibitors, which are pills that can be taken to go into the body and find cells that have too much activation of cyclin-dependent kinase 4 and 6 and turn it off, stopping the cell from undergoing cell division. Scientists actually began to look at these inhibitors in cell lines first at a number of different pharmaceutical companies. And in their experiments, they didn't actually identify that these inhibitors were going to be very active against cancer cell lines. So it had sort of a stunted growth. There was a lot of passing of inhibitors from one company to the next company, trying to find a cancer cell type where it would actually work.
So then, I guess what were some of the key milestones in the history of CDK4/6 inhibitors in breast cancer? And I'd really love to hear about the contributions of the Department of Defense Breast Cancer Research Program. As I understand it, Dennis Slayman had an Innovator Award where some of this pivotal research in breast cancer went on.
Yeah, so Dr. Slayman, who is highly supported by this DoD Innovator Award, has a large laboratory where he has procured a number of cell lines, cancer cell lines across different diseases, breast cancer, lung cancer, etc. And he actually has about 50 breast cancer cell lines representing the heterogeneous nature of breast cancer. So some are triple negative, some hormone receptor positive, etc. And he established a collaboration with one of these companies who had an inhibitor to CDK4 and 6 and offered to look at the inhibitor across the cell line panel that he had. He actually had a very smart PhD scientists in the laboratory who looked at the way these preclinical or lab-based tests to look for sensitivity of CDK4/6 inhibitors were being conducted. And he figured out a couple of key factors that the pharmaceutical companies hadn't figured out in order to find where these drugs work best. And using his techniques, and this PhD scientist was Dylan Conklin, using these techniques, he identified that hormone receptor positive breast cancer cell lines were exquisitely sensitive to inhibition by CDK4 and 6. And so Dr. Richard Finn and Dr. Slayman were so excited by these data, they presented it to the pharmaceutical company who actually gave Dr. Finn and Slayman the go-ahead to conduct a phase 1 trial to evaluate the drugs in patients with ER-positive metastatic breast cancer. I actually enrolled several of the patients back in 2007 as an early career faculty and saw patients have incredible responses. These were previously untreated patients in the metastatic setting. One of the patients continues on this drug, which is now known as palbociclib. So her disease, all these years later, has not developed resistance to it and remains under control. So those really positive results led to a larger phase 2 study, which ultimately showed there was a doubling in the time that patients would experience worsening of their disease by the use of palbociclib when added to an aromatase inhibitor. And this led to the accelerated approval of the first CDK4/6 inhibitor in 2015. Wow. Really exciting.
Yeah, that is. So I guess, thinking about how the clinical impact and usage of these drugs. So CDK4/6 inhibitors, as you say, have significantly changed the landscape of breast cancer treatment for women, especially with hormone receptor positive metastatic breast cancer. How would you say these drugs, these CDK4/6 inhibitors, and I know there are three different varieties of them, really have transformed patient care?
These have made a substantial impact. If you consider that hormone receptor positive breast cancer is the majority of breast cancer, about 75% of all breast cancer is hormone receptor positive. And these drugs, which now include not only palbociclib, but ribociclib and abemaciclib, have all been shown to almost double the amount of time patients can experience disease control with metastatic ER-positive breast cancer. In fact, in the early stage or curative setting, two of these agents, ribociclib and abemaciclib, have been shown to improve the chances of not having a recurrence after curative intent treatment when you add that to the regimen. So, and moreover, and most importantly, I would say, we also have evidence that these agents, in particular ribociclib and abemaciclib, improve how long patients live with metastatic breast cancer. So overall survival is sort of the gold standard measure of how well a drug works, and that endpoint has been met in studies relating to two of these CDK4/6 inhibitors. So it really is hard to overstate the impact these drugs have had. Not only do they appear to have activity in ER-positive breast cancer that's HER2 negative, but we have emerging evidence that there is activity of these drugs in ER-positive, HER2-positive breast cancer. And so we're seeing studies emerge in that subtype as well.
Wow. So in that instance, are patients also being treated with trastuzumab or Herceptin?
Yes, in HER2-positive disease, trastuzumab is given alongside the endocrine therapy and the CDK4/6 inhibitor. It's not yet approved, but the studies are looking pretty promising.
Wow. Okay. So what are some of the most significant clinical trials, I guess I would ask, that you've seen that have really shaped the current use of CDK4/6 inhibitors?
The studies that were designed and led to the full approval of palbociclib were the PALOMA studies. So PALOMA 1, 2, and 3, conducted in metastatic breast cancer, either in the frontline setting, meaning in patients who had never received medicine for their metastatic disease, that's PALOMA 2, and then in patients who'd already received a line of therapy, that was PALOMA 3. And again, both showed that adding palbociclib to endocrine therapy improved how long patients experienced disease control. The ribociclib studies were named Mona Lisa trials. So there was Mona Lisa 2, 3, and 7, all of which showing that ribociclib added to endocrine therapy improved progression-free survival and overall survival for patients with ER-positive, HER2-negative metastatic disease. And for abemaciclib, the studies were known as the MONARCH studies. MONARCH 2 and 3 were the most important. So all of those were in the metastatic setting. In the early stage setting, ribociclib was studied in a large trial called NATALEE. We've seen the results presented and published now, showing that adding 3 years of ribociclib after chemotherapy for high risk or intermediate risk early stage disease improves invasive disease-free survival. And then the MONARCH E trial showed that abemaciclib in the early stage setting improved outcomes for patients with high risk ER-positive, HER2-negative disease.
Okay, so so it has been approved then in the early setting. It's primarily used in the metastatic setting, and that's where we've seen significant improvement on patient outcomes. But now it is advancing into the early stage. So I guess let's turn a little bit to patients' experience and outcomes. From your perspective, how do patients generally respond to inhibitors in terms of, I mean, you've already talked a bit about the effectiveness, but what about the side effects? Maybe elaborate on that.
Yeah, it's absolutely a hugely important factor to consider. It's an important endpoint in clinical trials, these patient-reported outcomes and safety. So not just safety and toxicity we can measure based on tests, but actually how a patient is feeling based on standardized, validated surveys. All of these studies that I've mentioned have included patient-reported outcomes as part of their endpoints, making sure that our patients who are treated with the drug are not miserable. It wouldn't be a win if we're delaying the progression of disease, but the patient feels just awful. And these studies have all generally shown that the patients who are treated with CDK4/6 inhibitors have a delay in their deterioration of quality of life parameters. In general terms, in terms of toxicity and side effects, the CDK4/6 inhibitors are associated with a lowering of the white count, neutropenia. This is something patients are usually not aware of. We don't see many patients have infections or fevers or get hospitalized, but it is something that patients need to be monitored for. Fatigue is a symptom added with these. Some people notice hair thinning. They do have different side effect profiles. So for example, with abemaciclib, there's more diarrhea that we need to monitor and help patients manage. And with palbociclib and ribociclib, we have to monitor things like the blood counts, the liver function, EKGs for ribociclib. So these are things that can interfere with the quality of life because patients are having to come in and get blood checked and see their doctor for the first few months on therapy. Overall, I would say in the scheme of things, when you compare quality of life to things like chemotherapy, these are much better tolerated. And overall, I think the improvement, the therapeutic index of these agents, taking into account side effects, is in favor of using these.
Right, right. So some individuals with hormone receptor positive breast cancer don't actually respond to CDK4/6 inhibitors. Can you shed some light on why this occurs, and maybe even why other subtypes like triple negative don't respond to these treatments?
Yeah, it's an interesting question. There are patients who have primary resistance or primary disease resistance to CDK4/6 inhibitors, meaning when you treat them with the CDK4/6 inhibitor, the tumor does not respond at all and in fact progresses quite quickly. And this is something that's very, I would say it's fairly uncommon, but we see it in patients who have lower expression levels of ER and whose tumors are behaving in an endocrine insensitive way. So there are factors such as loss of retinoblastoma protein, cyclin E amplification, and other factors including PI3 kinase pathway activation. So these are areas that are under a lot of research, but in the clinic setting, we can't always discern what is happening in an individual patient's tumor that is rendering it insensitive to CDK4/6 inhibitors. Then you'll have patients whose disease responds and then develops resistance. And again, that's another area that's being evaluated, and these pathways I discussed, PI3 kinase, et cetera, may be implicated. In terms of triple negative breast cancer, tends to have a higher chance of having cyclin E amplification or loss of RB, which can render the tumor insensitive to CDK4/6 inhibitors. In order for these drugs to work, the cyclin-dependent kinase retinoblastoma pathway needs to be intact. So if any of those areas are not functional or present, then inhibiting the pathway actually isn't going to impact the tumor.
Right. So in the instance where they're not sensitive to the CDK4/6 inhibitors from the start, are they also then endocrine resistant?
They
Generally,
tend to have they tend to have endocrine resistance in that situation. And these are patients who seem to recur on adjuvant endocrine therapy quite quickly, or not respond to single agent endocrine therapy in the metastatic setting and just sort of blow through it. And if we profiled these tumors, I think a lot of them would tend to be in the basal-like or luminal B subtype, and there will be factors or features of the tumor that indicates the tumor is being driven by a pathway that is not part of the estrogen pathway.
Right. So are there biomarkers, specific biomarkers that can really help us determine whether or not a patient is going to benefit from CDK4/6 inhibitors?
At this point, the most reliable biomarker is hormone receptor expression, ER and PR. We don't have any other clinical biomarkers that will help us select a patient who is going to experience benefit or resistance from these agents. In fact, in the study that Rich Finn led, Paloma, the Paloma 1 or 2 study, Trio 18 study, where he enrolled 130 patients and randomly assigned to palbo-letrozole or letrozole alone. There was a part of that study where he restricted it based on biomarkers that they had developed or evaluated in the laboratory that appeared to pick out patients who would be most sensitive to it. And it didn't actually pan out. Patients seem to have the same chance of response regardless of their P16 status, which was one of the biomarkers they used, or not. So that's why right now ER is the main thing we look at.
What about the level? I mean, I've been hearing more recently about there being ER positive, but like low expression, less than 10%. Has there been any evidence that, looking a little more triple negative is indicative of not responding, or do we know?
Yeah, we have fairly good evidence that patients with ER of 1 to 9% of their tumor is not going to be endocrine sensitive and is actually behaving more like a triple negative tumor. Most clinicians are not super eager to utilize endocrine therapy, including CDK4/6 inhibitors in this situation. So I am looking at level of ER expression, and somebody who has lower expression, I wouldn't be really optimistic that endocrine therapy and a CDK4/6 inhibitor is going to impact the disease.
Right. All right. So, well, let's kind of talk about some of the challenges and maybe some of the future directions. So, despite the success, we know that there are of CDK4/6 inhibitors, and they truly have been remarkable. There are still some challenges and limitations in the use. What are some of those ongoing challenges? And I'm thinking too also about the fact that we have moved these into the adjuvant setting. What happens when individuals unfortunately go on to progress to a metastatic diagnosis after they've utilized CDK4/6? So what are some of the challenges, that maybe being one of them, and how is research addressing these issues right now?
I think we highlighted one of the challenges, which is the development of disease resistance to these agents and the other pathways that are upregulated in a tumor that help it develop resistance to this treatment. One of the ways that scientists are looking at circumventing this is by combining CDK4/6 inhibitors with PI3 kinase pathway inhibitors. At San Antonio, they presented data looking at inavolisib with palbociclib and endocrine therapy in frontline endocrine-resistant metastatic breast cancer, and showed really compelling outcome results indicating that this adding this PI3 kinase pathway inhibitor could actually be beneficial and delay progression in patients. The problem is when you start adding drugs all together, you're increasing toxicity. So careful attention is going to need to be paid to patient-reported outcomes, and also making sure we're doing our due diligence to try and identify biomarkers to help with patient selection.
Right. So I guess finally what I would ask is, what does the future hold for CDK4/6 inhibitors, and what are the next generation treatments or combinations, with other, and you described some of those, but are there other CDK inhibitors that are being investigated?
Yeah, the benefit of CDK4/6 inhibition seems to be strongly related to the activity of inhibition of CDK4. So there have been scientists and drug companies who have been looking at selective inhibitors of CDK4 and also inhibitors of other CDKs such as 2 and 7 and 9 to try and circumvent resistance or improve efficacy. A lot of these agents are in clinical development. The problem with small molecule inhibitors, which are chemical compounds, is it's hard to be really selective toward one target. There's usually a little bit of off-target toxicity. But I think they're making headway in this regard, and we're going to see some interesting data in the coming years relating to these novel therapies.
Okay. Well, were there any questions that I didn't ask that you think I should have asked?
Well, Michelle, you're always so thorough. This was great. You really you explored the entire topic so well, and it was such a pleasure to be interviewed by you. Thank you.
Well, thank you so much for your time and your insights today. Your work really does continue to inspire and provide hope for so many. And we look forward to seeing the ongoing developments in this crucial area of breast cancer treatment. So thank you so much, Sara.
Thank you.